Good morning. I am Dr. Neeraj Mishra, Assistant Professor in the Department of Pediatrics. And in next 40-45 minutes, I will take you to the journey of neonatal resuscitation. So what is the magnitude of the problem here? So in India, when you will look for the causes of neonatal death, so 20% is contributed by birth asphyxia, and this 20% of death can be prevented. Majority of this 20% case of birth asphyxia can be prevented by a skilled neonatal resuscitation program and neonatal resuscitation team. So that much important is the neonatal resuscitation program is there. That's why the neonatal resuscitation program or NRP guidelines are being made by American Association of Pediatrics, and this guideline is revised every 5 years. And the governing body for this NRP guideline is ILCOR, International Licensing Committee on Resuscitation. So again, coming to this pie chart, you will see that causes of death in India, preterm is 35%, sepsis 15%, and birth asphyxia is 20%. So 1/5 of the death can be prevented by a good neonatal resuscitation. So you can see how much important this NRP is. Why to learn neonatal resuscitation? Actually, as per 2016 data, it is 24%, so around 1/4. By appropriate resuscitation, outcome of thousands of newborns can be improved by an adequate and good neonatal resuscitation. 10% of all babies require resuscitation, 1% need extensive resuscitation. Ten 10% of all babies require resuscitation. Out of that, 1% need extensive resuscitation. And neonatal resuscitation is quite different from adult resuscitation. Actually, in adult, the cardiac arrest mostly is due to heart disease. But in neonates, majority of the cardiac arrest is of respiratory origin. Having said that, in neonates, it is the lung, it is the inadequate oxygenation of the lung which contributes to the cardiac arrest. So heart is not beating properly due to lack of oxygen. If you will provide oxygen to the heart, heart will start beating automatically. Here, per se, there is no pathology in the heart. Only heart is deprived of oxygen. That's why it is said and that in cardiac arrest in newborns is of respiratory origin. So you have to take care of the ventilation part. Okay. And usually caused by problems with respiration. Adults, it is most important in chest compression. In newborns, most important ventilation of the neonatal lung. Where in the adult, it is the chest compression or circulatory part you are taking care of. ABC of resuscitation. So the sequence of neonatal resuscitation is also different from adult resuscitation. In neonatal resuscitation, the sequence of resuscitation is temperature, airway, breathing, circulation, and drugs. T, A, B, C, and D. Temperatures is the first and foremost important things in neonatal resuscitation. That's why the ILCOR has made that the index of quality of resuscitation is the admission temperature in NICU. You have resuscitated a baby well in labor room and you have transported the baby to NICU. How the NICU team member will know that you have done a good resuscitation? So ILCOR has given an index temperature. If your baby is hypothermic, your quality of resuscitation is low. So NICU admission temperature is used as an index for quality of resuscitation. Other things while resuscitation you have to take care is airway, breathing, circulation, and if needed drugs. So if you will see the need for resuscitation, it is an inverted pyramid. So all baby requires the warmth, position, drying, sometimes stimulation, and suction if needed. Oxygen, less baby requires. Further down the line, assisted ventilation with positive pressure button, some baby require. And intubation with the trachea, very rarely, and drugs, chest compression further down, and drugs further down. So you are seeing the inverted pyramid. That need for resuscitation is going down and down as we progress. So, and when you are doing chest compression and giving drugs to the baby, it is called extensive resuscitation. So how will you prepare for resuscitation? Preparedness. Every delivery, one person with skills to perform complete resuscitation. High risk, two or more persons is required. Multiple but separate team for each baby. Equipments, warm. For temperature maintenance, you need a warmer. For clearing airway, you need a suction. For ventilation, you need ambu mask or TP resuscitator. Then oxygen, all the equipment needed for intubation, and all medications required for resuscitation should be available in the delivery room. So this is the algorithm of resuscitation, and according to this algorithm only you have to proceed. So you are seeing here there are two types of boxes. One is this one is your square box, and another one is diamond box. So a square box for action and diamond box for observation. So first and foremost thing is antenatal counseling, team briefing, and equipment check. As soon as you enter the labor room, you have to do these things. Then after the birth of the baby, you have to ask 3 questions to the mother. Term, is the baby term? Tone is good, baby breathing or crying or not? If answer to all these questions is yes, all these questions, not one, all 3 questions yes, baby will stay with the mother and routine care will be provided. Routine care consists of warm and maintain normal temperature, position airway, clear secretions if needed, dry and ongoing evaluation. If answer to any of the question is no, means baby is not tongue, baby is not breathing, or baby is not crying, then the baby will be taken into the radiant warmer, and you have to do the initial steps. What are the components of initial steps? Warm and maintain normal temperature, position, airway, dry and then stimulate, and clear secretions if needed. After that also baby you have to assess. After this initial steps, you have to assess the baby and check for is the baby apneic, is the baby gasping, or heart rate below 100. Okay, so what you will do? If baby apneic, gasping, or heart rate below 100, answer to all these questions is no, then you will go for the further evaluation. Means heart rate is more than 100, baby is breathing and gasping, but is the baby having labored breathing or persistent cyanosis? Okay, yes, then position and clear airway, SpO2 monitor, supplemental O2 as needed, consider CPAP. Fine. If answer to the question is yes, means heart rate below 100, then you have to start positive pressure ventilation. And positive pressure ventilation should be started within 1 minute of the birth of the baby. And as soon as you will start positive pressure ventilation, you have to attach SpO2 monitor and ECG monitor. And SpO2 monitor should be always attached at the right upper limb. Okay, so you have given positive pressure ventilation, and then you have to assess the heart rate. Is the heart rate below 100? Then, if after 30 seconds of positive pressure ventilation, which moves the chest, after that also heart rate is below 100, then you have to go for chest compression. Okay. Check chest movement, ventilation correction steps if needed, and heart rate below 60, then you have to go for chest compression. Intubate if not already done, chest compression, coordinate with positive pressure ventilation, 100%. Whenever you are starting chest compression, you have to give 100% oxygen and ECG monitors are already placed. And after 1 minute of chest compression, still heart rate below 100, then you can go for medicine. This is the Dawson nomogram for pre-adapter SpO2 target. So 1 minute target should be 60 to 65, 2 minutes 65 to 70, 3 minutes 70 to 75, 4 minutes 75 to 80, 5 minutes 80 to 85, and 10 minutes 85 to 95. So this is the Dawson nomogram, and as you are seeing that a normal saturation in a newborn will be reached by 10 minutes of life. These are the equipments needed for a neonatal resuscitation. Out of that, I have told you warmer is needed and plastic wrap for less than 32 weeks gestation, for clearing airway, bulb syringe and suction catheters, for auscultation, stethoscope, for ventilation, flow meter, and it should be set at 10 liters per minute. Oxygen blended has set to 21%. In term baby and for preterm 21 to 30%. Oxygenate, then intubation, all equipment needed for intubation like PT tube, blade, stylus, carbon dioxide monitor, all should be needed. And medications mainly normal saline and epinephrine is being used. So these two medications should be ready, and ECG monitors, SpO2 monitors. This is the oxygen meter with which you can titrate the percentage of oxygen and you can adjust the flow. And this is the radiant warmer, pulse oximeter, ECG monitor. So these are the equipments needed for neonatal resuscitation. You are seeing that the bulb syringe, normal syringe, epinephrine, ambu mask, laryngoscope blade, suction catheter, and plastic wraps are there. So if after the birth of the baby is strong, tone, breathing, or crying. Okay, answer to all these questions yes. Then baby will stay with the mother and warm and maintain normal temperature, position airway, clear secretions if needed, dry and ongoing evaluation. Routine care consists of putting the baby on mother's abdomen, delayed clamping of cord, drives, clear secretions, and continuing monitoring. Initial steps consist of, if answer to the question of tone, breathing, or crying, the initial steps we should go. And initial steps consist of warm and maintain normal temperature, position airway, clear secretions if needed, dry, and then stimulate. So initial steps: provide warm, position, clear airway, dry, reposition, stimulate. Radiant warmer, the heat is provided by radiant warmer. Less than 32 weeks baby, you have to go for the plastic wrap. And while resuscitation, baby head should neither be flexed nor should be extended. It should be in neutral position. Wet skin promotes rapid cooling, so proper drying has got importance, because due to dry, if you will not dry the baby body will be, if there is a moisture on the baby's body, what it will do, it will evaporate and it will take heat from the baby body and baby will be hypothermic. So proper drying is very, very important. And while drying, after drying, the wet linen should be removed. That's why three wet linen is needed. While gently rub the newborn's back, trunk, or extremities, do not do vigorous stimulation. Okay, if at all needed. Suction mouth and then nose. And suction is highly discouraged in now modern neonatal practice, because suction has got so many adverse effects. So suction should be done only when it is absolutely essential. When you are seeing visible secretion in the baby's mouth or nose, then only you can go for suction. Otherwise, suction is not warranted. And suction should be the last step in your initial steps. So you have to look for respiratory effort, heart rate. You should find out by the stethoscope, and you have to, how you will calculate the heart rate. Auscultate the baby's heart for 6 seconds, and whatever the value you are getting, multiply by 10. So suppose you have auscultated the baby heart for 6 seconds and you got a value of 10. So you will multiply 10 into 10, it is 100. So baby heart rate is 100. Because you have in 1 minute there are 60 seconds and you have counted the heart rate for 6 seconds. So you have to multiply by 10. Meconium present and vigorous baby. If respiratory effort is good, muscle tone good, heart rate more than 100, then initial steps are done on the mother's abdomen. There is no separate algorithm for meconium aspiration nowadays. And use bulb syringe or large bore suction catheter to clear mouth and nose. If baby has labored breathing or persistent cyanosis, then position and clear airway, SpO2 monitor, supplemental O2 as we can consider CPAP. Acrocyanosis, I told you 10 minutes it will take for the normal saturation to reach. So acrocyanosis will disappear after the 10 minutes of life. What to do if baby has no respiration, low heart rate? Then you have to go for, after initial stage, you have to go for positive pressure ventilation, and positive pressure ventilation should be started within 1 minute of birth. So indication for positive pressure ventilation: apnea, gasping, heart rate less than 100 beats per minute, and persistent cyanosis despite 100% free flow of flow. And as I told you, most of the cardiac arrest in newborns is of respiratory origin. So ventilation is the most important step in neonatal resuscitation. So what are the devices by which you can give positive pressure ventilation? You can give positive pressure by self-inflating bag, or commonly called ambo mask. It can be given a flow inflating bag, or it can be used by TP's resuscitator. So all three can be used for neonatal resuscitation. Most of the units, standard units in India now using TP's resuscitator, but TP's resuscitator is costly. So most commonly used throughout India is self-inflating bag or ambo mask, and I think you may be familiar with this ambo mask. So what size of mask you should select for a baby for resuscitation? So a mask, either round mask or anatomical mask, can be taken. But while selecting the mask size, you should take care of some points. One thing, that mask should cover both angles of the mouth and it should cover nose, but it should not cover eyes. So you can see this mask, correct size mask. It covers both angles of the mouth and nose, but do not cover eye. Okay, this mask is an anatomical mask and also correct size mask. But see here, this mask is not correct. It covers eyes. It covers eyes. So these are the incorrect size masks. So appropriate size mask is the mask which covers angles of mouth and nose and does not cover eye. So in 2015, this is a major revision in the neonatal resuscitation guideline. So with what percentage of oxygen you should start resuscitation? In a term baby, you should start resuscitation by 21% of oxygen. But a preterm baby less than 35 weeks, you should start resuscitation with 21 to 30% oxygen. Why we are so much confused in giving oxygen is that oxygen is a drug and it can cause harm. If we give more oxygen, it can cause damage to the heart, it can cause damage to the lung, it can cause damage to it will generate free radicals and it will cause injury to the lung. So less than 35 weeks neonatal resuscitation should be started with 21 to 30% oxygen, and more than 35 weeks you should start with 21% oxygen. And depending upon response to resuscitation, you can titrate the oxygen. How much to squeeze and how frequently you should squeeze? There are two questions. So when you are squeezing, whenever you are in positive pressure breaths, adequate chest rise visible chest rise should be there while you are doing positive pressure ventilation. And your rate of squeezing or rate of positive pressure ventilation should be 40 to 60 per minute. And how will you count 40 to 60 per minute? So you have to follow the rhythm: breath 2 3, breath 2 3, breath 2 3. So while resuscitation, you should shout, breath loudly, breath 2 3, breath 2 3, breath 2 3. Okay, so breath 2 3 squeeze and release. Breath squeeze 2 3 release. Breath, you give breaths and 2 3 release. So by this way, if you do, it will come around 40 to 60 per minute. Check the baby's heart rate after 60 seconds of positive pressure ventilation. And after 15 seconds, there will be three conditions. So heart rate is increasing. Then announce heart rate is increasing. Continue positive pressure ventilation. Second heart rate assessment should be done after 15 seconds. Second condition is heart rate is not increasing, chest is moving. Announce heart rate not increasing, chest is moving. Continue positive pressure ventilation that moves the chest. Second heart rate assessment should be done after 15 seconds. And third condition, which is the worst, is heart rate is not increasing, heart rate is chest is not moving. Announce that heart rate is not increasing, chest is not moving. Ventilation correction steps that MR SOPA, Mr. SOPA should be done. And until chest movement will be intubate or laryngeal mask airway if needed. Announce when chest is moving, continue positive pressure ventilation that moves the chest. Second heart rate assessment after 30 seconds of positive pressure ventilation that moves the chest. So this is Mr. SOPA. M, R should be done together. S, O should be done together. P alone and A alone. So M is mask adjustment. R is reposition airway. So M, R should be mask adjustment. Reposition airway should be done together. And try positive pressure ventilation and reassess after 15 seconds. Suction mouth and nose and open mouth. And then again reassess. Then increase pressure and then alternative airway. And alternative airway can be of two types, either laryngeal mask airway or endotracheal tube. Second rate heart rate assessment after 30 seconds of positive pressure that moves the chest. Then if heart rate is at 100 beats per minute, continue positive pressure ventilation to 40 to 60 beats until spontaneous effort comes. Heart rate will be 60 to less than 100. So reassess ventilation correction steps if necessary, and less than 60 beats per minute. Reassess ventilation correction steps. Insert an alternative airway. No improvement after perception and chest compressions. So this is the technique of intubation. Intubation should be completed within 30 seconds. Once you are putting the laryngoscope in the baby's mouth, that endotracheal intubation should be completed in 30 seconds. So what are the indications of intubation? So there are few indications: ineffective positive pressure ventilation, prolonged positive pressure ventilation, if chest compression required to facilitate coordination and efficiency of ventilation. Following conditions like CDH, surfactant administration, tractor suction required. Now it is not recommended for vigorous newborn in MSL. Previously it was an indication. And now also, if thick secretions are there, baby born out of MSL and you are seeing the vigorous secretion, you can go for tractor suction. So these are the few indications of intubation in neonates. There are the equipments required for intubation. One is ET tube, your handle, blade, battery, a stethoscope for the confirmation of the position, measuring tape for measuring the depth of insertion, whatever the depth left, and your scissors, suction catheters, all. Insertion of ET tube, it is how much length depth you should go. It is nasotracheal length plus 1. This is the formula, or simple formula is weight in kg plus 6. So how will you confirm the position of endotracheal tube? There are few methods by which you can confirm the position of endotracheal tube. So if bilateral breath sounds equal breath sounds are, rise of the chest on both sides, no heart, no air entry in the stomach, no gastric dissension, and if you have CO2 detector, you can capnography will tell you. And heart rate increase is the most sensitive sign of neonatal resuscitation. So heart rate is increasing, then your ET tube in place, and it can be later confirmed by the chest X-ray. And the correct position of the ET tube is between T1 to T2, just above the bifurcation of the trachea, above the carina. So if a baby which is intubated, you are doing positive pressure ventilation, or if you are kept on ventilator and baby start deteriorating suddenly. So what can be the cause? So it is, this cause can be summarized by the famous pneumonic tube, displaced endotracheal tube, obstructive endotracheal tube, pneumothorax, and equipment failure. This is the tube. So what are the complications of intubation? If there is a delay in intubation, hypoxia, bradycardia, apnea can occur. If you will give more positive pressure breaths, it can lead to pneumothorax. If you are twisting and tilting during intubation, it can cause soft tissue injury, and this can lead to infection. Chest compression. For starting chest compression, this is a golden line you should take. It's very, very important when to go for chest compression. There is always, especially for the new students, this is always a question when to go for chest compression. So you should not start upfront the chest compression. Chest compression should be started if heart rate is less than 60, despite 30 seconds of effective positive pressure ventilation. Having said that, the positive pressure ventilation which moves the chest, and it has to be given till 30 seconds. Then, and if heart rate after that also is 60, then you should go for chest compression. And whenever chest compression is started, two people are required. One person will give positive pressure ventilation, other will start chest compression. The person who is giving positive pressure ventilation should stand on the head end, and the person who is giving chest compression should stand on the foot end. And how we can provide chest compression? There are two techniques of providing chest compression: two thumb technique and two finger technique. But now two finger technique is obsolete after 2015 revision, so only two thumb technique is preferred. Okay. And in which area you should provide chest compression? Chest compression should be provided in the lower 1/3 of the sternum. You should avoid pressure on the direct pressure on the G5, otherwise it will break. And how will you know the 2/3 of the sternum? Just below the nipple line. The 2/3 of the sternum is just below the nipple line. You should give the chest compression. And what depth should be given? The depth should be 1/3 of the epidiameter. So this chest compression should be coordinated with the positive pressure ventilation. And in 1 minute there will be 120 events, 90 compression and 30 breaths. Okay. So here the ventilation and chest compression ratio should be 3:1. 93 chest compression to 1 ventilation. How will we coordinate? Here 1 and 2 and 3, and you have to compress the chest, and breathe in, you have to give positive pressure. So here the ratio is 3:1. This ratio is different in adults. I told you that the cause of cardiac arrest in adults is different. It is of mostly the cardiac pathology which causes cardiac arrest. But in newborns, it is the lung which is the culprit. Heart per se is fine. Heart is not getting oxygen. That's why the cardiac arrest is happening. If you will give oxygen to the heart will beat normally. So in neonatal resuscitation, we are focusing more on the ventilation of the lung, whereas in adult and pediatric resuscitation, we are focusing more on the circulation part. That's why the chest compression to ventilation ratio is different in adults. So 2 seconds, here are 4 events. So 1 second, 2 events. So total 120 events in 1 minute. So when you will stop chest compression? After approximately 30 seconds of chest compression and positive pressure ventilation that moves the chest, still heart rate is less than 60. And if more than if heart rate after 30 seconds, you will check the heart rate, and if heart rate is more than 60, you can stop chest compression. If and continue positive pressure ventilation at 40 to 60 beats per minute, between 60 to 100 heart rate, baby beating spontaneously, heart rate more than 100, and baby is pink, you can stop, slowly wean off the positive pressure ventilation. Medications, what are the drugs required? Mainly 2 drugs used in neonatal resuscitation: epinephrine and normal saline. And this a third drug may be required, the PRBC, rarely. So, and majority of the time, these two drugs will be sufficient. So, when you will go for drugs. So, after other drugs has no role like naloxone, sodium bicarbonate, calcium gluconate, atropine is now obsolete drugs. And when to use medications, despite administration of effective chest compression, effective positive pressure ventilation, with 100% oxygen and heart rate below 60, okay, then you can go for drugs. Before going for drugs, recheck for the effectiveness of ventilation, chest compression, and endotracheal intubation. And another conditions you can, other differences you should keep in mind like hypervolemia and severe metabolic acidosis. So here the normal saline 0.9% or suspected anemia O negative packed red blood cells can be given. This can be given by intravenous route only, or if intravenous route is not available, you can go for intraosseous. And it should be administered over 5 to 10 minutes. How to prepare and give epinephrine? So, commercial epinephrine which is available in the market is 1 in 5,000 dilution. So, this you have to dilute 10 times. Means 1 ml of this commercial preparation with 9 ml of NS, it will become 1 in 10,000 dilution. And dose is now as per 2020 NRP, dose is 0.2 ml per kg of this diluted epinephrine. Other name of epinephrine is adrenaline. So this diluted adrenaline 0.2 ml per kg should be given to the baby. And preferred route is intravenous, I told. And if intravenous route is not available, you can go for intraosseous route or intratracheal route. But why you are giving the intratracheal route? You should not count the doses given by the intratracheal route because absorption of epinephrine by intratracheal route is quite erratic. We don't know how much adrenaline has been absorbed through this route. That's why this dose is not counted. Okay. If after all this the baby is not reviving, then you should think as one of the causes hypovolemia, and then you should go for volume expander. And volume expander in NRP is either normal saline or PRBC. Okay, so volume expander. When you will think of volume expander, when poor response to resuscitation, evidence of blood loss is there, like vasa previa. Baby is pale, pulses are poor, and CFT is prolonged, then you can go for volume expander. Recommended solution, I told you, is normal saline, ringer lactate, and O negative blood cross match with mother's blood. So these are the normal volume expanders, but most commonly used volume expander is normal saline. Dose is 10 ml per kg. It should be given by umbilical vein. So intravenous access you have established to umbilical vein. If umbilical vein you are not getting, then you can go for peripheral access. And this should be given about 5 to 10 minutes. While the epinephrine should be given as fast as possible. And this you should keep in mind that if when you are giving the rapid bolus, this 10 ml per kg of bolus over 5 to 10 minutes, this is rapid bolus, and it may cause intracranial hemorrhage, it may cause intraventricular hemorrhage. So hemorrhage risk is always there with your rapid bolus in neonates, especially preterm neonates where the passive circulation exists. IVH can be there. And these are the changes in the 2020 NRP. So I will like to tell you that what are the changes in the 2020 NRP. So in 2020, there are changes in the 4 pre-birth questions to be asked. So previously, 4 pre-birth questions were gestational age, amniotic fluid clear, how many babies are additional risk factor. But now the 4 pre-birth question has changed. It is gestational age, amniotic fluid clear, additional risk factor, and 4th one is umbilical cord management plan. So what is your umbilical cord management plan? Now additional risk factor. How many babies have been removed, and you should go for Fourth question is umbilical cord management plan. Another change in the initial steps. As I told you, previous sequence of initial steps are warm and maintain normal temperature, position, airway, clear secretions, and dry stimulus. But now suctioning, as I have told you at the beginning of the class, suctioning has been condemned. There are so many adverse effects of suctioning, and this suction first or drying first was the major highlight in 2020 revision. That's why now suction has been further downgraded. So in initial steps, the last step is the suction. So warm, dry is to make position airway. And if needed suction should be given only when you are seeing the visible secretions in the baby's mouth or nose. And whenever you are doing suctioning, mouth should be first and then followed by nose. And you can remember very well with the mnemonic. M comes first in the alphabetical order after, and then comes N. So mouth first, then followed by nose. Now, the cardiac monitor, ECG monitor should be attached to the babies whenever you are starting physical ventilation. One major change in the dose of epinephrine, previously it was 0.5 to 1 ml of, dose of saline plus was 0.5 to 1 ml normal saline, but now fixed dose is given for either premature baby or term baby. It is 3 ml of normal saline. Dose of epinephrine has also got changed. Previously, it was 0.1 to 0.3 ml per kg, or when you will take in mg, it is 0.01 to 0.03 mg per kg. Okay, and range of endotracheal dose was also changed, 0.05 to 0.1 mg per kg. Or in ml, you will take 0.5 to 1 ml per kg. So you can remember like that 0.1 to 0.3 ml per kg and 0.5 to 1 ml per kg. But no need to remember, this is the old guideline. As per new guideline, it is 0.2 ml per kg and endotracheal route is 1 ml per kg, 5 times higher. So there is no discrepancy, nothing. You can remember the dose of epinephrine, diluted epinephrine is 0.2 ml per kg fixed for all baby, and if you are giving by endotracheal route, it is 1 ml per kg. While giving endotracheal route, I told you that absorption of epinephrine is quite erratic from endotracheal route. So dose of this endotracheal route should not be counted. Okay, and fixed dose is given 0.2 ml per kg of the diluted epinephrine. Dilution is 1 in 10,000. And how many doses of epinephrine can be given? There is no fixed criteria that how many doses can be given, but normally it is given every 3 to 5 minutes, and 3 to 5 doses can be repeated for neonatal resuscitation. Another question: if once you have started resuscitation, when you will stop resuscitation? How long you should continue resuscitation? So this guideline also has got changed in 2020 revision. So if you are doing resuscitation and heart rate is less 0, means Abgar is 0, there is no activity, there is no respiratory effort, no heart rate is 0, no body movements, nothing is there, and so and you have spent your 20 minutes in resuscitation, you can stop resuscitation by 20 minutes. So take home message is, if Abgar score is 0 after 20 minutes of resuscitation, you can stop resuscitation from case to case basis. This is not a fixed thing that at 20 minutes you have to stop. You can stop at any time. Fine. So you can still after 20 minutes, if you want, you can prolong. If you are thinking that your baby is going to improve, okay, so you can continue resuscitation. But a general guideline has been given that if you are thinking that baby is not going to survive, baby is not going to be revived after 20 minutes, you can stop your resuscitation. So these are the major highlights of 2020 revision. Actually, we were expecting some more changes in 2020, but only few changes were made in 2020. But these changes are also critical, and you should be updated with the NRP. NRP is one area where, with your small effort, you can make a large change in somebody's life. I hope this class would have been useful, and you will try to learn from this class and resuscitate the baby in a nice manner so that baby life will improve. Thank you.